All right, so we're going to be covering three concepts today: mood and affect, cognition, and stress and coping. Next semester, y'all are going to get psych, special pops. And each one of these concepts is going to be a 2-hour presentation because there are a lot of exemplars y'all will be getting that are affiliated with these concepts, okay? So we're going to introduce the concepts to you, right? In level 1, we are learning what? The nursing process, and what type of patient are we working with? Normal. Next semester, y'all are going to get the abnormals, and these are the ones. These are the things you're going to see, the abnormal parts of these concepts, okay? So, mood and affect, mood is subjective. Affect is objective. So, how are we going to describe mood? Where are we going to get that data from? The patient, right? And where are we going to get the objective data from? What we observe, okay? So when I look at that patient and I say, how are you feeling today? And the patient's sitting all crumpled up in a ball and going, I'm fine. Are they really fine? They're saying the right word, but are they really non-verbally showing you that they are? So their affect is different. Their mood is different, okay? They may be saying their mood is good. So we're looking at some of the buzzwords you're going to read in psych are affective instability. That affect is changing. The way they look, the way they present themselves. What can they do functionally? Their ADLs, are they able to do their regular things, their regular activity of daily living? Activities of daily living. Can they do that? You're going to see that someone who's having mood and affect problems cannot do that. Are they depressed? Melancholy? Those are the things we're worried about. Are they manic? Are they hypomanic? So when we look at the continuum, eurythmically, we want to stay here. We don't want to be in melancholy. We don't want to be in mania. We don't want to be bouncing off the walls up at the top. We don't want to be down at the bottom, depressed and sleeping all the time. We want to stay in this eurythmic zone that's out here. So when I look at this morning when I woke up, I felt fine. Got up, did everything I normally do, ate my breakfast, got in the car, driving into school. As I got closer in here, my head just filled up. So I went from up here to down here because pollen, sinuses, pressure, so when I got into to work, I took an antihistamine and everything else. Now I'm probably in the middle here. I don't feel real great, but I don't feel as bad as I did a couple hours ago. So, mood, affect, how I'm feeling, where I'm working, I'm in that eurythmic zone. If I'm really feeling bad and crummy, I'm dropping down. If I'm so elated and jumping up my skin, I'm above the line. So we want to look at that. We want to see where we stand. We don't want to see, we can see mood swings, but we don't want to see them real erratic, up and down, up and down. So what are some of the things we see? Mainly it's interpersonal relationships, okay? So that patient may say, I'm not feeling good because my wife left me. It's a good reason, you could be talking to the wife and just say, my husband hasn't been acting the same lately. He's been, kind of not doing things. So we're going to assess their interpersonal relationships. What's the perception of the patient? What's the perception of the family? A lot of times the patient doesn't know they're having a problem. They think they're fine. They're saying, oh, I'm good, I'm okay, I don't have a problem. And then the wife or the husband or the children are saying, Pete ain't so good. He hadn't been acting right. Okay? So we're going to assess those interpersonal relationships. What's somatic complaints? Somatic. Somebody say something. What? What? What's somatic? You're not that brain dead. I know y'all finished the test. I know y'all behind you. But what's a somatic condition? Right. I mean, it's the physiological things. You know, my toe hurts. My stomach doesn't work right. You know, something somatic. Those increase. They become more somatic. When they get to anhedonia, when they just don't feel pleasurable of anything, they don't want to watch TV. They don't want to go to the football game. They don't want to go out to eat. They just want to stay in the house. They want to stay in the bed. That's kind of low, right? They're way low on that scale. You're going to see fatigue, sleep disturbances. They may not sleep all day. I mean, all night. They may be insomniac. They may not be able to sleep. They may sleep all the time. Maybe too much sleep. Okay? And all of this leads to increased potential for what? Suicide. That's the big thing we're worried about. So depending on how this patient is describing, they'll say, I'm sad. You know, if they're hopeless, where are they on that continuum? At the bottom. That's not good. What if they're losing weight? That's not good. What's happened to, what activity of daily living's messed up? Eating, right. I mean, you got to eat. Maslow, right? What's at that bottom rung? You know, their sleep patterns, their fatigue, their energy levels. You know, they'll say, I feel worthless. I just flunked this test, and I am bad. You know, you're feeling bad. You're feeling worthless. You're down at the bottom down here. And then when you start feeling like that, what ends up, I'm worried about? Harm to yourself. I'm worried about patients like that. So some descriptors, some of the things that you're going to see in a chart are in table 28.1. Appropriate is appropriate, right? I'm acting properly. You know, I respond appropriately. I'm answering the questions appropriately. My affect is appropriate. Inappropriate is not right. Not doing it correctly. What's full range mean? If I say full range, none of these definitions are hard, but what's full range mean? It's not appropriate for y'all not to answer me. Y'all are being inappropriate. Speak to me. You engage your brains. I know y'all didn't prepare for class because y'all were studying for form, but this isn't wrong. What's full range mean? Just say something. Anybody? Right. I mean, so if I ask them something and they're supposed to laugh and they laugh, that's good. If I say, oh, I see here that your wife died 2 weeks ago. How do you feel about that? And they're sad, that's range, right? So full range, if I ask them something that makes them happy, they respond up. If I ask them something that makes them sad, they respond down. They have full range, and it's appropriate, okay? So I'm looking for that full range. Is it stable? So what's stable mean? Right, it stays in that eurythmic thing. So, I mean, if they're high, if they're low, but if they're stable, they're answering appropriately, they're not answering. When your wife died 2 weeks ago. Yeah, I know, that's no problem. That's unstable, right? They're labile, okay? So they're answering inappropriately, labile. When I ask them something they should be sad with, they're elated. When I ask them something they should be elated, they're labile. They're bouncing up and down. They're going all around. Elevated, no matter what I ask them, it's all great. Everything's good. Everything's wonderful. You know, everything's working out fine. Depressed, nothing's working. Everything's down below the line. No matter what I do, even if I give you that 6 Mounds candy bars during clinicals that makes you smile, you still don't feel good, right? Overreacting is when they take something and blow it out of proportion. when it goes way over the top. Now, these are the bad ones. Blunting. What is blunting? What do they look like? What do you see? What are they blunting? What does, I mean, just don't overthink it. What, if you think blunting, what do you think? Short, blunted, dull, you know, they're not reacting, they have a flat effect. It's just nothing I say changes the way they look. Nothing I say, they don't smile, they don't frown, they don't really react very much. It's blunted, it's flat. It's very, I'm worried, okay? I'm really worried about this patient when I see him like this. Has anyone seen a blunted effect? Yes? That's wonderful. So a blunted effect, we see that a lot of times from the students, right? Since my funny guy in the back is trying to be a joker this morning. All right, so blunted is something that concerns us. If we see that in a chart, we're going to be concerned about things. So our exemplars, how do we assess for mood and affect problems? What do we need to do? So we know, like any other thing, we have to establish that therapeutic rapport. Sometimes it's hard to be non-judgmental. We have to be able to look at them, be able to talk to them from a non-judgmental approach. Small time intervals. A person who's in either a high or a low, can they focus? So when we're talking to them, how long does it take for us to do an assessment? Are we going to do an assessment in a minute or two? No, it's going to take several minutes, right? And I mean, some people, 5, 6, 7 minutes, they're pretty good. They're pretty quick. They can get everything they need. Some people, 10 or 15. I don't know. It just depends on what we're dealing with. But these patients, you may have to break it up. You may have to go in and go do a couple minutes, then stop. Go back in, do a couple more minutes, and then stop. So small time intervals. Look at everything. Can they focus? What do you think focusing? How do you think they are focus-wise? Yes? No? Maybe so? What do you think? Right. I mean, if they're on one end of if they're eurythmic, they probably can, but we're talking about someone who's out of the norm there. So we probably have to refocus them a lot of times. We probably have to make them look at things a little bit more differently. And really focus on that Maslow part, that bottom rung. Are you eating? Are you sleeping? Are you taking care of your daily activities? Are you bathing? Are you combing your hair? You're going to see these patients. The ladies are going to not have makeup on, or maybe makeup on one side of their face. I mean, it can be extreme, okay? They're not combing their hair. Men don't, are not shaven. They're not, those things are apparent. Those things become very, very visible, okay? But we need to talk to the patient about that. We need to assess why they're not able to take care of those types of activities of daily living. And your common characteristics, 28.3. So remember, those are some nice testable boxes, tables. All right. Did we post these to Canvas? Did Ms. Yondron post these? Okay, they're in your book. Okay, and this is not testable, but when you get to level 2 and level 3, these inventories will become more apparent. Ms. Yondron, did y'all use this GDS? Did y'all see that at the nursing home? Yeah. So, I mean, geriatric depression scale, you can do it. Next semester, you're going to see the Beck Depression Inventory and the MDQ. And this is when you get to level 3, you're in special pops. This is level 3, special pops. What are these scales good for? What do they do for us as nurses? They what? What do we like as nurses? What type of data? Objective and what? Measurable, right? So what are these things going to give us? A number, right? So is it easy to write a care plan and a nursing diagnosis to say we got a GDS of 75 and we want to see that patient get to 85 by the end of the week? Absolutely. So we want to use scales whenever we can use them. So recognize that if when you get to these different levels and you're having to write care plans and you're using these things, use these to your advantage because it makes it a lot easier to write your care plans. All right, so lifespan, cultural considerations. There's our big friend right there, age, right? Age is always a question. And something that is the biggest ideological thing we got on any type of concept that we're dealing with. Cultures. Are cultures influential on mood and the way people act? Absolutely. I mean, our mores, our cultures, our expectations, these are all very much part of what happens to individuals. So Eastern cultures are different than Western cultures. Shoots, people who live down the bayou are different than people who live in the city, right? We make our groceries in the city, right? Everybody understand what that means? Where are you from? Yeah. He doesn't know what making groceries means. Right? Is that you're going to Schwagman's and making your groceries? Hello? Is he Western culture? Way west. Where are you from? Seattle. Seahawks? Oh, yeah, I thought so. Anyway, he doesn't know what that means. You think someone from Vietnam knows that, or someone from South America? I mean, there are things that happen culturally that we need to understand. So when we're taking care of a patient, we have to understand, we have to empathize, we have to look at what's going on with them culturally to understand their mood and affect. I mean, how do people react? Men are what? Much more stoic than women, right? Man's going to go, I am not in any pain. And then they're going to say, okay, why don't you get out the chair? Okay, I'm getting up. You're not in any pain. No, I'm fine. Whereas a woman, mood and affect is going to be different, right? So sex, cultures, race, psychosocial, what's going on with that patient? We do an extensive psychosocial background, right? Y'all got a bunch of questions I know that y'all ask, okay? So all of these things are necessary to understand that mood and affect aspect of things. Okay, when I look at diagnostic studies, this is all physiological, right? These are things that we're going to test because if I'm not feeling right, if my blood sugar's off or my thyroid's off, how am I going to look mood-wise, affect-wise? Not good. I'm going to be different, okay? So a thyroid function, how do hyperthyroid people look? Yeah, they're off the top of the wall. Their hair's falling out, their eyes are bulging, they're skinny, they eat all this food, their metabolic rate's way off the charts. So I'm going to run a thyroid function. This patient may be real manic, showing manic features, but they're hyperthyroid. If I fix that thyroid, they come back in the eurythmic phase, okay? What about electrolytes? Do they affect us? Okay, so, I mean, when we look at electrolytes, if we've got any type of imbalance, it can show. It will be a problem. Your analysis tells us a lot about what's going on. Tox, how long does it take for a tox screen to come back? Depends on where you send it, but it's not a result that's going to be out in an hour or two. Your analysis, electrolytes, thyroid function, couple hours we're going to have a result. Okay? Tox screens take a little longer. Okay? Does the liver and kidney affect anything? Absolutely. So if that BUN or creatinine are elevated, or if we've got those LTFs, those liver functions that are off, that's a problem. What about pregnancy? Does that affect your mood? Yeah. So sometimes a pregnancy test is needed. Y'all laugh, but it's true. Okay? Before I put a patient on a psych unit and thinking they're crazy, and they're pregnant and crazy, that's a different thing, right? So I want to run all of these screens and these tests to understand if there's a physiological underlying condition that may be causing something to happen with this patient, okay? So due diligence is I'm going to look for this. As a nurse, I'm going to say, hey, doc, have we run all of these tests that are done there? So that's pretty much mood and affect. Y'all are going to get more exemplars next semester in psych, and y'all are going to pick it up. But these are the concepts that are touched by the mood and affect part of things. Okay, cognition. Cognition is our perception. What do we perceive is going on? Our memory, our executive function. That's our higher thinking processes. Those are the things we're worried about. This allows us to be flexible. This allows us to be adaptable. Cognitive function. This allows us to set goals. Okay? So we're looking at the cognitive level of functionality here. So who's our highest risk? The older population, right, is our highest risk. What about personal behaviors? What are some personal behaviors that put us at risk? Drugs, alcohol, lifestyles. You know, our younger people have personal behaviors, right? Teenagers are what? Bulletproof. They'll do crazy things, right? Learning disabilities, that's 23-2. Those are people with, dyslexia, ADD, things like that. 20 years ago, we didn't have that. We didn't have the ability to test people for these learning disabilities, okay? But would that cause problems? Would you see swings in moods? Would you see things affecting cognitive, higher functioning parts of you if you can't focus on things? Absolutely. So cognitive-wise, we're going to worry about what this patient, does this patient have any of these issues, disability-wise? Intellectual disabilities are those that you're born with, like Down syndrome, Fragile X syndrome, things like that. So that's something and I mean, ADD you're born with too, but these are more physiological manifestations, right? Down syndrome, people, have a different physiological look. Dementia. Is this patient, have they been diagnosed with dementia? What's going on with them as far as, can they remember what they did? Can they remember what they ate? Can they remember if they took a bath? Right? Health-related conditions. That's all of the hypertension, the glycemic effect, the thyroid. Any health issue could cause a problem with cognition, correct? What's our gold standard for measuring cognition? Somebody said it. What? No. What do we want? Joker in the back of the room, say it out loud. Glasgow coma. We want a number. Think like a nurse here, guys. You know, don't go to AAO3. Is that really going to give us anything? No, but a 14, a 13, a 15, that's measurable. That's a number. When we can get a number, we want it, okay? So that's basically what we're dealing with when we're looking at those patients. That Glasgow coma is a big thing that we're using. So when we're talking to a patient about cognition, and if we suspect that there are cognitive issues that are going on, we want to prepare the patient, because people do not like surprises. They want to know what's going on, okay? We want the patient to be in a good position if they're sitting in a chair or if they're laying in a bed, or even if the patient is a little bit hyperactive and wants to stand up and walk around. We want them to be in a position that's okay, and we want to be in a position to be able to observe this patient, okay? A lot of the stuff we pick up on these three concepts are nonverbal. What's nonverbal? What percentage of communication is nonverbal? A lot, right? More than the verbal. So as that patient's talking, I want to be observing what's going on. Do you think that, once again, I showed you assessment skills on language. If I tell my friend I'm going to make my groceries, or he says, I make my groceries every Saturday in the morning, and I'm from Seattle and I'm the nurse, I don't know what the hell he just said. He's making groceries. I think you're kind of crazy. How you make groceries? Right? I mean, what did you think when I said that? I mean, you're trying to put it together. You're in class. But if I'm in a room and I'm assessing and I'm saying, what do you do for your groceries? I'll make my groceries every Saturday. From Seattle, you would go, he's kind of, he's off. He's a little off. He's not fully with it, right? So I want to know language skills, okay? You don't have to be a foreign national to have problems with language skills. You know, people with a French background, an Italian background, there are words I use as an Italian my mother taught me that my kids don't understand. We went to the St. Joseph altar, and they don't understand what we said. I understood. My generation understands. The younger generation does not, because they were not raised in that environment. So the food we ate, the things we did, they didn't understand it. It's cultural. It's language skills. Okay, level of orientation. You know, we want to know, where are they? Do they know the time? Do they know the date? You know, can they gauge where they are, what they're doing? They're AAO3. Where are they? What goes first as far as orientation and memory? Yeah, I mean, you looking at a demented patient, what do you expect? Short term, mid-term, long term. Short term goes first, right? So you'll be talking to the patient and they'll say, oh, you know, when I was in high school, I took Mary to the prom and ABC band was playing. They know long term what was going on. What'd you have for breakfast? Did we have breakfast yet? So when we're assessing orientation and memory, where are you? I'm in the hospital. What's your next question? What hospital are you in? I'm in University Hospital. What's your next question? How many university hospitals are there? in the country? So what's your next question? Where? New York. I'm with my daughter in New York at University Hospital. She hadn't come to see me today. No, you're at University Hospital in New Orleans, Mr. Keller. Right? So what are we trying to teach you, baby nurses? Question, more questions, right? Dig, dig, dig. Just because they say hospital doesn't mean they know where they are. Just because, now, if I'm at St. Charles Hospital or I'm at, what if I say I'm at Ochsner Hospital? How many campuses does Ochsner have? Not hundreds, but a lot, right? I mean, so you see what I'm saying? So we have to know. When we assess, we have to dig. We have to go down. Computation ability. One of the things you're going to do a mini mental exam on your patients. Subtract, start at 100 and subtract by 7. 93, 80. I mean, you can see that's, you can go back. And as you computate backwards, people have to concentrate, right? Another thing they'll say is apple, water bottle, coffee cup. Say that. Apple, water bottle, coffee cup. They say it. Now, I'm going to come back to that in a few minutes. So I talk to them for a few minutes. I interview them, do different things. What were those 3 words I said a few minutes ago? Yeah, we know that now. But can y'all remember that 5 minutes from now after we've talked about the Pelicans game and where you live and how's your daughter and what's your other, comorbidities? So we're checking memory. We're checking computation. We did the moods and affect on the other side. We want to look at how they are. We want to observe what's going on. And we want to check their decision-making ability. Okay? Are they making their decisions properly? All right? So, if their normal day, if they normally go to make their groceries on Saturday morning and it's Thursday afternoon and they're at the grocery store, something's changing. Something's changing. So we have to understand what their normal activities are, what's going on. A lot of times the family members will tell you, Daddy's just not acting the same. Mom is doing things different. She gets up and makes her coffee and scrambles her eggs and does this morning. She didn't drink any coffee. She didn't scramble eggs. She went and ate cereal and, something's different. Something's not right. So remember that our interventions need to be independent. We want to keep the patient as independent as they can be. But we want to make sure it's a safe environment. Okay? So we want to make sure that when we put that patient in their home or wherever they're going to be safe. They're going to be able to handle things that are not, that won't hurt themselves. We want to orient the patient. We want to make sure they understand what's going to be going on, because they have been, this cognitive function, they are disoriented. They have lost that ability to understand things. As patients lose this ability to do this, stimuli affects them. If they're in a room that's real bright, that has a television on, that has distractions and there's a lot of noise, if they're in a restaurant and it's loud, they'll become very quiet. They're afraid. They're out of their environment. They don't know what they're doing. My father, when he approached his demented phase of life, he had some issues with his heart. He came out the hospital. We brought him to my sister's house. He's a wreck, peeing on himself, pooing on himself, not sleeping, not doing anything. Brought him home. He was fine. He's in his own house. He knew where the bathroom was. He knew where things were. He didn't know where the bathroom was at my sister's house. So he would have accidents. We try to set up eating schedules. He didn't know what was going on, so he was afraid. Got home, if we went there, we put the food in front of him, he ate it. At my sister's, he wouldn't eat. So we got to look at the environment. We've got to see what's going on, okay? Of course, younger people, we got the TV on in the den and the radio on in the kitchen, right? I mean, that doesn't bother us, but to them it does, right? So those things that you got to realize, you got to know what's going on. We've got to educate people as to how to handle situations like this. What do you do? I mean, now that we have done this, if I would have educated my sister better, maybe he could have stayed at her house. But we didn't know that at that time. We didn't realize it. Dignity is always a big thing. We always want to make sure we keep that person's dignity. And I mean, the biggest thing that ends up happening is one afternoon, I went over every day at 5 o'clock to feed him after I got off of work, pulled up at 5 o'clock, the house is open, the garage is open, the car's gone. Where's Daddy? He was in AFib. He was having to go to Cognition lab every Thursday to get his blood drawn, right, to get his INR to find out if he's therapeutic. I went to the grocery store. I went to the drugstore, because where did he go? He went to the drugstore and the grocery store and the hospital. I didn't think about the hospital, all right? So I called my sister frantic. I'm like, I don't know where Daddy is. What's going on? You know, do we call the police? What do we do? What do we do? What do we do? And he goes, well, you know, he's got Cognition clinic tomorrow. Did you go to the hospital? And I went, I'm headed that way. Well, guess what? I pull in at Ochsner main campus, 5:30, third floor, parking lot. His brown car sitting in the middle of the parking lot. No other cars there, because that's the spot he parked all the time when there was a lot of cars there in the morning, right? He was there by himself. I walk in. Has anyone been to main campus lab? Second floor, big room, a lot of people. Walk up there. It's around 5:30. Sitting there by himself, sitting in her thing, little Florida sweatshirt on, his hat like JP in the back, sitting there quietly, sitting and waiting. And I look, lights are off, nobody in the clinic. I go to open the door, and it's locked. And I'm like, and he's waving at me. And I'm saying, hello, come here. So he walks over, he opens the door, because it's got the electric locks, right? Everything locks down at 5. What the hell's going on? There's bad weather or something? Nobody's here. I said, what do you mean? Well, I'm coming to get my blood drawn. It was when the time changed. He had taken a nap. He had fallen asleep. He thought the sun was coming up. So what did we have to do? What happened? What happened? What happens when they take your keys away? It's the hardest thing you're going to ever have to do in your life. You know? So there are, you know, you want to do the best you can. We had to negotiate for several months. You know, what do I have to do to get my keys back? But I mean, eventually, you know, everything worked out, you know, but you want to maintain, we allowed it as long as we could till something put him at risk, right? We couldn't do that anymore. So we started to have to collaborate now, right? I mean, my sister and I could handle it up to then. Now we worried about Daddy. Where's he going to go? Is he going to wander? Is he going to do this? Are we going to leave him at home? What are we going to do? So we had to look for community resources. We had to look at other things. So as you progress down this, keeping this independence as much as you can, you're going to get to a stage where you're going to have to call in for some help. So you look at the community. Pharmacologically, we had to change meds. We had to do some different things. So we'll, you know, as you go through the different stages, you're going to look at these types of interventions and therapies that are out there. Okay, our exemplar is delirium. Okay? And delirium is going to be something that happens quickly. Okay? So you can observe restlessness, involuntary motions that are done by the patient, lack of muscle coordination. They may have difficulty swallowing. They may not be able to name the patient, name you. I mean, I go in, hey, I'm Pete. I'm taking care of you. Okay, fine, Pete. 9 o'clock, I go in, give meds. Oh, you saw the game last night? Pelicans, they're not doing so good. Yeah, that was bad. You got season tickets, don't you? Yeah, I got season tickets. Everything's fine. Go in at 11, here, getting ready to get your lunch out here. Who are you? Well, wait a minute. 2 hours ago you knew who I was. What do you mean? Well, I mean, are you my nurse today? That quick. It can happen, okay? So, we're going to look at that. We're going to look at everything that's going on. They may not be able to speak. They may look at us and now they're like saying words that don't make sense. So we're looking at the different things that are happening when we're taking care of that patient. Usually it's a physiological type of thing. It's going to be progressive. They're going to be characteristics. So we're going to observe all of these things that are out there. What are the motor signs? What are the effects of speech? I just went over all of those things. How their memory. So what can cause this delirium? What do y'all think causes this? Hello? You can take a break if we get past this slide. Low oxygen. What else? You open the door. What? UTI, tired. Give me a better one than tired. Give me a better. That's a sign and symptom. What's causing it?
Neurological.
Like what? You really stretching hard. Did you have farm yet? Yeah. Oh, okay. Your brain's out of whack here. Okay. It's something physiologically. Blood sugar. It could be oxygen. It could be, what does sodium affect? Cognition, right? So if my sodium levels change, if I got a patient that's on Lasix and I'm diuresing them out and they just peed 2 liters, I gave them a Lasix shot. I gave them an IV, 40 milligrams Lasix at 9 o'clock. At 11, they don't know who I am. What's coming out with that pee? Sodium, right. If that sodium levels drop, that patient is going to be kind of out of it, okay? Can I fix that oxygen problem? What can I do? Give them oxygen, huh? Sit them up in the bed. I can do things, right? Can I fix that high blood sugar? What can I do? Give them insulin. What if they got a blood sugar of 50? Can I fix that? If I got a sliding scale, right? Just like I can give them insulin, but I give them sugar. What happens when I give them the sugar to this delirium? But, okay, they don't know me. They don't know what's going on. I give them the sugar. Are they going to know who I am now? Yeah. It's going to reverse what went on. I'm going to give them their insulin, and when that blood sugar comes back to normal, oh, what's going on, Pete? How are you? They're at 85 sats. They come up to 95. Man, I don't know what happened. Just had a little episode here. You're all right. I can fix it pretty quickly, okay? But it's reversible is my point, okay? What if I give them some Abilify at 9 o'clock? And 10 o'clock, they're bouncing off the walls. 11 o'clock, they're bouncing off the walls. 12 o'clock, 1 o'clock, 2 o'clock. How long is it going to take for them to come out of that delirium? You just had your farm test. How long? Speak up. Pharmacokinetics, right? How long does it take for that med to get out of the system? Right? I got a med, I give it BID. How long is it effective if I'm giving it BID? 12 hours, right? What if I got to give it TID? What if I got to give it daily? So that medication, I got to know pharmacokinetics based on to understand how long this delirium may present itself. I can fix some of them pretty quickly, but they're all reversible. Okay? Delirium is reversible with interventions. It just depends on what intervention we have to do. Okay? So that is what we're looking for. Okay? But these are all of the things you're going to see, your signs and symptoms and different things that you're going to worry about with delirium. That's table 23.5. Okay, so that's cognition. So mood and affect, cognition done. Take a little break and we will continue on stress and. All right, so now we're going to start on stress and coping. Okay, stress and coping. So today we had farm, right? Or going to have farm, right? So we're stressing, and how are we coping? Do what? Yeah, that's what I'm saying. The people who have finished are finished. The people who aren't here are cramming. Is that good to cram? The people who sit in the back of the room have their cards and they're still studying and thinking that I don't see them reading their cards. But they're cramming, but at least they show up for class, So their coping mechanisms, their stressors that are going on, And I'm polite enough usually not to say anything when you're studying, but I want to say it for this because it's a good example, of how we cope with stressors, right? Everybody copes differently depending on what the stressors are, okay? So remember that stress is an event or demand made on us individually, okay? And coping is how do we handle this demand? How do we manage it? How do we take care of it? Do we see it as a no stress, challenging, threatening? We want to figure out what it is. So we're going to figure out what that stressor is. We have to identify it as nurses, and then we have to figure out the coping strategy, right? So we're going to assess the stressor, and what is the coping going to be? What type of nursing process are we in when we're talking about coping? What's ADPI? What is it in ADPI? Is it an assessment? No. It's an intervention, right? How you're coping. Who's studying in the back? Raise your cards. You see? Look. All my students, too. Right? They do this in clinicals. So they don't think I see it. They don't think I know. But so I'm going to evaluate about what time? 2 o'clock? 2:30? How'd you do? Did that coping strategy work? Mr. Keller, I made a 60. That cramming didn't help me. So that strategy didn't work. I assessed their stress, a test. Their intervention is, I'm going to study during class, but I'm going to come to class to watch you because you're funny and you make me laugh. And then I'm going to evaluate, how'd you do, Shelby? Not so good. Sad face, huh? Sad emoji. Or we'll be a happy emoji. I did great. I got an 82. Shelby says, don't make me turn pink. All right. So we're going to use our strategies, right? Remember, most of the problems y'all had on test 2 was trying to figure out what's an assessment, what's an intervention, what's an outcome. All of this, I've done assessment, interventions, outcomes on 3 concepts when we finished this. Did I have assessment, interventions, and outcomes up on the slides? No. Do y'all have any questions? If you do, you come talk to me. Okay, we're not going to make it so obvious that that's going to be it, because is it going to be obvious on the test? No. So why do I want to make it so obvious in a lecture, and when the test comes up, y'all are going to not do so good? So if y'all need clarification on the process when we're going through any concept, that's what it's all about, okay? So come to us and talk to us if you don't understand. What are the interventions for mood and affect? What are the outcomes? If you read it in the book, they're usually in the book, but if you don't understand them, come and talk to us. We'll focus you, okay? So what types of stress? When I'm talking about types, I'm doing an assessment, right? I'm trying to figure out what the stressors are. So I'm looking at trying to assess, is this a biogenic stressor? Is it something that is directly responsible, something that'll trigger it, okay? Is it that 5th cup of coffee? Can that cause stress? Yeah. Can that 20 milligrams of nicotine in the inhaler thing cause a stress problem? Right. So is it biogenic? Is it something that's going on? Is it something I can track back to something you're doing? Yeah, I mean, no, right. But, well, it could be. I mean, it could be a drug. It could be something. But I'm saying that I'm thinking that normally we self-medicate, right? I got antihistamines on board right now, right? So I may not be acting totally right. And you may ask me, why are you acting like that, Mr. Keller? Well, I'm really tired. Look at my eyes. Look, I'm puffy. I got this. Why are your eyes puffy? I took some antihistamines, okay? So, I mean, or it could be a medication I'm taking. I could be having a lisinopril effect, right? My tongue swells up, I can't talk. That's a side effect of prills, right? Pharmacology. What happens if that tongue swells up too much? I stop what? Breathing. It's not good. So we're going to look for biogenic stressors, okay? Psychosocial. Do we do a good psychosocial assessment? How many pages, how many questions do y'all ask your patients when you're doing your psychosocial? No, I'm not saying you do enough, but there are a lot of questions, right? So we're looking, is it environmental? You know, and depending on the level of stress that people are in, they may be imagining things, right? They may think that things are not there. We're going to talk about that. So, you know, we're going to go through this. And it all depends on, we're going to go back to what was our cognitive appraisal of this patient. You know, where did we put this patient cognitively? Were they fully there? Was their Glasgow coma what? 15, or was it a 14? So I got to know this before I start talking about stressors, before I start talking about things like that. Okay, so other type of stressors are developmental, right? So we're going to have different things that come up. When I'm in my early 20s, I don't have the same stressors I have as when I'm in my midlife at 40 or 50. When I'm 60 or 70, my stressors are different than what they were when I was 40 or 50. They change, okay? So depending on the stage of development you're in, your stressors are going to be a lot different. Internally, that happens too. What am I physically? Every day I change, right? I got up today, I had sinus issues. I got a lot of pollen in the air. Tomorrow I get up, I'm not going to have that issue. Tomorrow it'll be something else. So physically, spiritually, you know, cognitively, where am I? Where's my individual? So that's individual things, things that affect Pete Keller, things that affect me. And it's definitely what I have that's dealing with me. Environmental are the things outside of our demands that disrupt homeostasis. This morning, my coffee pot wouldn't work. Oh, Lord. Not good. Starbucks time, right? I know, but I'm saying that I also have coffee at home, too, all right? but the thing is environmentally, that disrupted my life, right? I'm stressed now, right? I got to pull the app out real quick and make my call, you know? So, I mean, so what's going on? Let's do this one. My flat tire. That's better? Okay. So, walk outside and I got a flat tire and farm is in 20 minutes. What am I going to do? I'm just going to put the gun to your head right now and just let it happen, right? I mean, so, you know, it's out of my control, right? I mean, there's nothing I could do. I should have woke up an hour earlier, but I didn't, right? So it's out of my control, environmental. So box 31-1 gives you those types of things. Okay, the coping process. So we're going to do our cognitive appraisal. Remember back when our exemplar was assessment. So you should know what questions to ask, what things you want to look at from a cognitive perspective. Because if we don't know where that patient is cognitively, we are not going to be in a good space. There are assessment interview questions on page 1590. Now, which book, I don't know. But whatever 1590, when they have assessment cognition questions, I think it's the concept book. I'm pretty sure. Because these concepts come mainly from the concept book. So I don't think it's in Crozier. But anyway, those are some questions to give you a good cognitive appraisal. We talked about Maslow. All three of these, if we're not filling in that bottom part of Maslow, if they're not safe, if we're not eating, if we're not sleeping, if we're not being able to bathe, if we're not being able to take care of ourselves, we're not in a good place. So we have to assess where you are there on Maslow. We've got to look at where that patient is on that hierarchy of level. You know, are they safe? Do they feel loved? Do they feel like they belong? What is their self-esteem? What are the things that they're looking at there? Can they self-actualize at the top of rung of the ladder? That means they're independent. That means they're able to do all the things they can do on their own. So we've got to assess Maslow. That's figure 31-1. Okay? And then 31-3 is effective coping. So we're looking at problem-focused coping. You know, can they manage that stressor? Can they manage that circumstance? Can I get the jack out the back of the car, jack up the thing, change my tire, get here in time to take my test? Can I manage that stressor? Okay, it's problem-focused. I can fix it. If it's emotional-focused, it's more of a distress. It's like a problem focus, I can fix it. I can get rid of it. An emotional focus is more like a reactive type of thing. I'm going to react to something. It's generally, I don't think I can change it. I'm going to try my best and I'm going to do what I can. But it's not as clear-cut as changing that tire, right? I mean, so it may be, how do I study for these tests, right? You won't know how you're going to react to that till you take your next test. Did the flashcards work? Did writing in my own language work? You're going to change different coping strategies to try to get to it. So you're emotionally trying to take care of this. And then you're going to reappraise and you're going to adapt. So in this coping process, what am I doing when I'm at these two levels? What part of the nursing process am I in when I'm doing cognitive appraisal and Maslow higher needs? Where am I when I'm looking at effective coping? Interventions. And what am I doing down here with reappraisal and adaptation? Right. Different words. Nursing process. Okay? So recognize that this is what's going on. This is how we are working through that process. So we have a couple of theoretical models. The general adaptive syndrome. Do y'all know what that means? Anybody go back to A&P or biology? What's that mean? Someone that first class knew this, so I'm sure someone in here knows. Who's the encyclopedia? He's diverting his eyes. I've got you speechless? When he goes to that mode, he's really, I caught him. I got him. All right. It's the alarm reaction, right? It's when our body reacts to stress, fight or flight, okay? That's how we, that's one of the things we do. Alarm, resistance, exhaustion. So you go through that alarm reaction. We amp up. All of our senses amp up. Everything starts to go through everything. We get into a stage of resistance where we start to come back to homeostasis. And then finally, we're at an exhaustion stage where you're just kind of resting. You're just trying to get over everything. Okay? So understand that general adaptive syndrome. It's discussed in your book. The transactional model is there also. So your primary appraisal is you have to identify what's going on. What's the stressor? What's the threat? What's the challenge to the individual? So that primary appraisal is assessing what it is. The secondary appraisal is to say, what are some coping strategies you can use to fix this? So you're going to interact with the patient and see what do they perceive as things they can do to handle the stressor they're faced with. So, the stressor is, I just lost my kidneys. I got to go to dialysis 3 times a week. How are we going to help you cope with this new stressor? How are you going to be able to do this? Well, I don't drive anymore. I need a ride. Okay, we got to work on that. We got to help with coping. So that's secondary. Then coping is when we put those things into action. So we'll discuss several different mechanisms in the appraisal, in the secondary appraisal, but only maybe 1 or 2 may be something we decide we're going to do at the coping strategy. And then the last but not least is reappraisal, which is another word for what? Part of evaluation. Okay? So these 2 models you need to understand, you need to be able to look at. So when we're looking at stress and coping, these are our characteristics. What happens respiratory-wise? You doing what? Well, maybe not hyperventilating, but it's increased. Okay, cardiac? Increased. Integumentary, what's that? So what happens? Sweaty, yeah. Gastrointestinal? One or the other. It might be hyper, it might be hypo, right? How many had diarrhea effects this morning?
We are not answering that question.
Well, I'm just saying. Or how many people have not been able to go to the bathroom for 2 days because they're stressed out? Urinary. Same thing happened with the last class. You can't pee. It slows down. But what happens? What happens to sodium? You start to dump sodium. Okay, so your sodium levels are dropping. All right, so you're retaining urine, but the sodium concentration is going to be dropping. Okay. No, it's going into your urine. It's going into your bladder. It's hanging out. It's out of where it should be. It shouldn't be in your bladder. It should be in your brain and in your bloodstream, right? Ophthalmic, what happens to your eyes? Huh? I can't hear them. What? Blurry vision. Fight or flight. What happens when we fight? We're getting, we're looking, we're able to go out there, okay? Neurologically, what are we doing? We're bumping up everything. We're becoming more alert. We're hearing more. Musculoskeletal, what's happening? We're amping up. We're getting ready. And endocrine-wise, what happens? Yeah, you need more blood sugar because everything's bumping up, right? Our respirations are up, our heart's up, everything like that, okay? What are the two organs in the body that burn the most calories and work all the time? It is working all the time, but it doesn't burn the most calories. So it doesn't. The what? The heart and what else? The lungs, right? So as my heart rate goes up, as my my respirations go up, I need more energy. I need more glucose, okay? So as that happens, so when I'm looking at, I know that we look at vital signs, we look at trends, right? So when I'm looking at a patient, I don't have to have a patient that is tacking out at 150 beats per minute. I can have a patient that's baseline is 60 or 70, and now I notice that he's up to 80, 90 beats a minute. Is he out of normal? No. Below 100 is normal. But it may not be normal for this patient. This patient was breathing 12 breaths per minute. Now they're up to 16. Are they out of normal? No. They're bumping up, though. What's happening here? Something's going on. So I'm going to go in that room. I'm going to talk to him. What's going on? Doc left a few hours ago, and I don't have my kidney anymore. I got to start dialysis. Stress is kicked in, right? His baseline went up. Not a lot, but enough to warrant me as a nurse to say, something's going on, Cap. What's happening? What's going on here? I just found out I got stage 4. The pathology report came in. Why are you asking? Well, I'm just looking at your vitals, and they kind of bouncing up. The last 2 times you're coming up a little bit. What's going on? Well, I've been really worried. I've been really concerned. We have to use our ability to do our head-to-toe assessments. We have to know the data that's coming to us. We have to constantly be vigilant on what's happening with this patient. That's what we're looking at. Okay, so defining characteristics. Some of the things they're afraid, right? I found out I got stage 4 cancer. What am I going to do? I'm afraid. I don't know what I'm going to do. Did my anxiety level go up? Absolutely, if I don't know what I'm going to do. Am I mad? Probably so. Right? We got Kubler-Ross. You go through the different stages, depression, all of that. So they can show anger. They can show increased anxiety. These are all the characteristics you're going to see as that stress level amps up. So we got to look for that. We got to be aware of it. We got to look for those things that are out there. So when we're looking at defining characteristics, some of the cognitive indicators are, if that patient is really stressed, can they solve individual problems? It's probably becoming harder for them. Their cognitive structure, they're not really able to look at things the same way they did before. Cognitively, they're going to be changing. There's going to use suppression is going to be available. Those are ego defense mechanisms. They may not be able to handle, their self-control may not be that good, and they may resort to fantasizing, another ego defense mechanism to say, I can probably do okay. I think I'm all right. So they're going to fantasize. But we're going to look at these things and see if any of them are happening. Are they daydreaming? Are they able to stay in control of their own emotions? You know, which defense mechanism are they using? Which one are they working on? So your ego defense mechanisms are on table 36-1. And what is compensation? What would compensation be? What? Like, so what's that mean? Okay, so the example here is I wanted to play football in high school. I did, but I couldn't because I was too little, right? But really, what did I want to do? What was the stressor? I wanted to be active. I wanted to be an athlete. But do I need to be a football player to be an athlete? So I compensated by running track. So you see, it doesn't have to be y'all are looking more at negative things. It can be a positive thing. So I mean, I got stage 4 cancer. Not a good thing. But you know, are there people who have stage 4 that beat it? So if I've got it in a positive light, and I compensate that I'm going to do my chemo, I'm going to do this, I'm going to do that, I'm going to compensate, I'm going to fix it, okay? So compensation. All right, what's denial? Well, denial is, you know, okay, I got stage 4 cancer. My daughter's getting married in a year and a half. I'm going to plan the wedding. Well, you know, you're probably not going to be here. But I'm still going to go ahead. Now, is it bad? No. I mean, is it good for them to still want to plan their wedding? Absolutely. And you should encourage it. But don't think of ego mechanisms as bad. They're coping mechanisms, right? We have to make them positive for that patient, okay? But they're denying, right? I mean, more than likely they got a real short chain prognosis and they're planning something 18 months out and they probably got a 6-month prognosis for them. What's displacement? So tonight, don't go home and when you make that bad grade on your test, don't go home and fuss at your dog. That's displacement, right? You're really angry because you didn't do good on the test, but your dog's going to pay the price, right? Or your husband or your wife, okay? Identification. What's identification? Do what? Right. That's all it is for someone that, once again, with denial, also identification is, you know, when a patient knows that they're on a short stick, but they know they're gonna do all the things that they can to live, right? They're gonna take their chemo, they're gonna do that. So they've identified the positive things that they can do. So some of these can overlap each other, right? Okay, what's intelligization? Dun dun bum. Whatever that one is. Yeah, what is that?
Being intellectual.
I'm not gonna hit you.
Okay.
What? Being intellectual. What's that mean? That's answering a question with the question I just asked. What's in whatever? Say it again. What is that? Well, I mean, the example they use here is that my dad had a stroke and he died the next day, and I say, you know, he died, it's best because he wouldn't want to be a vegetable. We intelligently work through it by saying we don't think that should have been, right? Now, how many people know anything about strokes? You know, a stroke patient, how long does it take to realize whether you're getting anything back? How long does it take usually? Does it next day or whatever? It's 7 to 21 days. 80% of you should get everything. 80% of what you're going to get back is going to happen. So if someone has a stroke day one and they die the next day, that doesn't mean they would be a vegetable necessarily. They may be, but they may not. But the brain takes 7 to 21 days to compensate back. Y'all will learn that. So, but I'm intellectualizing it by saying Daddy wouldn't have wanted to been a vegetable. It's the best thing he died. So I'm using my intelligence to try to rationalize it. That's my coping mechanism. Introjection. What's introjection? Following it up. What's that mean? Well, it's introjecting. It's putting it into something, okay? So the example here is a 7-year-old tells their 6-year-old brother not to cross the street. They're introject. Does that 7-year-old really know about that? Where'd they learn that from? Mom and Daddy. So they, what they've learned from a higher source is introjected back in. Now this one you'll see a lot with psych patients. You'll see a lot with that. And I'm throwing these words out because when you get to psych and you get to the axis 2 behavioral, I'm trying to think of the right words, but these are the these are the defense mechanisms you're going to see the personality disorders. Okay, that's axis 2 personality disorders. These are the mechanisms you use. Minimization, what is that? Yeah, I'll do this, some people are going to do this afternoon, because they did good on their test. And usually that's what what y'all gonna do this afternoon after the test? No. Go have a cocktail and y'all gonna say, I can drive home. I'm minimizing, right? Have 3 beers. I'm okay. We know good and well that you're not. You're minimizing it. But, that's the example I use, is about driving when you've had a drink or two. Projection. What's projection? Pushing it onto somebody else. So, so the wife's all upset because the husband didn't pay the bills, right? My phone got turned off because you didn't pay the bill. Could that person have helped with it by reminding the other person that they don't want their phone turned off, so pay the bill? So, projection, and the projection for the psych patients are, my mama brought me in, PEC'd me. I didn't do anything wrong. They probably hit their mama. That's why they're there. When you read what happened in the police report, you're going to find that's what, when you talk to the patient, why are you here, man? I don't know, my mama put me in here. That's projection, right? Mama put you in here because you put a pan on the side of her head and she called 911, right? That's what happens a lot, okay? And then rationalization. What's rationalization? What? when you hit mama that hard. When a mother spanks a baby because they had an accident, okay? So, they had an accident in their diaper and they're like, you shouldn't be having accidents, you're too old. And they rationalize that. I've already taught you this, what's going on, And then repression. What's repression? What? Holding it in, right, and trying not to let it go, not really acting out and doing the things that should be done. So, that patient who finds out they got stage 4 cancer, all of a sudden they regress. They wet in the bed. They're regressing. They're going back. They can't bathe. They're expecting things to happen. So all of these things are, they regress back. Now these ego defense mechanisms, once again, are all coping strategies. They're things that are going on that we are going to do. Some of them can be bad or some of them can be good. It's incumbent upon us to figure out how to make the coping mechanisms work, to do the positive coping mechanisms, okay? So we're going to assess, box 31-3 is going to give us our assessment techniques, and we're looking for their behavior, their cognitive, emotional. So we want to know their current illnesses, their past illnesses. What are their somatic, their physical complaints? We want to know about those things. We got to have that general health history. What are their perceived stressors? What do they see as stressful? What is going on there? What are stressful incidences with them? How is that stress manifested? Because what their view is and what our view is totally different. It's individualized. Remember that, okay? And how did they cope? I mean, how I cope today is different than how I coped last week or last year. My coping strategies change. I'm a lot more laid back now than I was a year ago, 5 years ago. Things I did, the way I coped for my daughter's wedding was very maladaptive. I had some bad issues, but I learned from that, okay? So I'm going to cope differently when I'm faced with other stressors. You learn, you evolve, you develop, right? So we've got to check those things out, okay? What's the ability of that patient to verbalize these things? Some people can't verbalize it, but those nonverbal parts are coming through. There are problems. What are their motor abilities, their cognitive abilities? So we're looking at all of those types of things that are out there. So we're visualizing, we're on our head-to-toe assessment. What are we doing? Where do we start with this appraisal, this assessment? What's the first thing we're going to do? Yeah, but head to toe. What did I tell you? What's the little person we had up there? What can we notice? Hello? Start at the head and work your way to your toes. Hello? How are you going to assess the patient? You're going to do a physical assessment. Okay, so what's that? What is your thing? What's your scale? Pascal coma. Next. Where are we going to go? Head to toe. Come on. Quickly. What are we going to do? I'm going to get like Miss D. Come on. What's going on? Come on. What's going on? What are we going to do next after we get a Glasgow coma? What are we going to do? What are you going to do? What are you going to look at? What are you going to see? What did I put up there? You had the slide 3 slides ago. What did it say? Tell me what it was. What was it? What are you going to do? I got all ramped up. I'm stressed out, Mr. Keller. I can't cope. Katie, let me see your eyes. What did I say about eyes? What are they going to be? Okay, what else now that I gave you that hint? Respirations. What else? Heart rate. What else? What else? Miss Deek running around. What else? Go back to your notes. Go back. Come on. Hurry up. Katie, tell me. Diaphoresis. Right. What else? GI. Yeah, hyper, right? You're either constipated or you're diarrhea. You're not peeing. What's happening with the sodium? What's happening? Oh, I got edema. Is that a good interpretation of Mystique on the assessment? I got it. That's right. That's why I did that. Okay, so Assessment, are y'all pulling it together now with assessment? I mean, we always go back to that head-to-toe assessment. What's the signs and symptoms? Mood and affect, their signs and symptoms. Cognitive, for our stress and coping. We give you those things. Just tie it back. It's not hard. Y'all know it. And it's the same thing over and over again. But it's just what's going on with that particular concept, right? So recognize that that's what's going on. All right, so our interventions, okay? Table 31-7, so we're going to look at what's going on. We need to figure out what we can do for this patient. So the patient it may be physical exercise. It may be that the patient is going to, is at that point that they're at a little higher level of anxiety and they don't understand, so they might have to walk around the room. They may have to, sit in a chair. They may have to, pick the head of the bed up. We've got to make sure they understand. We've got to look at sleep and rest, right? That is where on Maslow? Way down at the bottom. If that patient's not getting their proper amount of rest, how many people function good on 4 hours of sleep? Anybody? Yeah, I know, there's probably one or two, but most of us don't. Okay. Right. So what is normal for that patient, for that individual? Most people it's 6 to 8 hours, some people more, some people less, but we've got to look at that and try to get those interventions, make sure they are achieving their rest pattern that they need. Does nutrition affect how you feel? All of this is Maslow, huh? This is all bottom rung of Maslow. And what about this guy? Y'all know about that one. 9 times out of 10, we are stressed because we have a deadline. We have something we have to do. We have time management issues. We have to know what's going on there. So our interventions we have to look at. We have to make sure we understand what's going on. So our exemplar is anxiety, okay? And this is our piece of the puzzle where we are going to feel impending doom. It may be imagined. Autonomic responses are kicking in. Is anxiety bad? No. Anxiety is a continuum, right? So mild anxiety, moderate, severe, right? So you can see, anxiety, panic, depression, more anxiety. So you get in this cycle. Most people have to have some anxiety to function properly. I mean, when you study, you got to have some type, am I going to finish on time? Am I going to be able to cook supper? Am I going to be able to handle things? So, anxiety is not a bad thing if it's controlled. So in our assessment, we're going to look at what causes the anxiety, because we got to come up with a plan of care, and it's got to be based off of what's causing it. Is it caused by an illness? Could it be caused by medications? Could it? Absolutely. So we want to look at that. We want to see what's going on. So we're going to review that. We went through how to appraise for stressors. There are 2 different ways to appraise. So you want to know about that. Alcohol and drugs are big identifiers here. So when I'm talking to the patient and I'm asking them a question, do you drink? Yes, I drink wine. How much do you drink? 1 glass a day. What's my next question? How big is the glass? Oh, it's at 64 ounce from the supersize. And it holds a bottle and a half. Just one. What's the big deal? So you see about the next question y'all want to start asking? Does that make a difference? I could have that little 4 ounce that you get and you pay $15 in the restaurant for, right? Or I can go get the $1.99 Boone's Farm and fill up my 64 ounce with a bottle and a half, right? Is it still $1.99 or is it going up?
It's pretty cheap.
It used to be like 59 cents when I was in school. The Apple Boone's Farm. I know it's inflation, it's up there, but, or the Mogan David was also a good one for a Saturday night. That's that darker color. All right, and then what's the physical assessment? What's happening physically? We want to know, because, I mean, can anxiety be caused from physical discomfort? Yeah. So we want to know that. So we got to look at and try to figure out, is it mild anxiety? If it's mild, we just manage the stressors. We modify your behavior, okay? So when we do test review and you come in and you talk to me, how do I study? What do? I ask you what you did. I decide, well, that sounded good, but you got to change this or you got to do that. We identify what's going on and we modify the things that you're doing. That's how you handle things. You know, the patient that doesn't have a kidney anymore, you know, how are they getting there? What's going to happen with their work schedule? I mean, can a person still work 40 hours a week and not have kidneys? Or are they totally disabled? They can work. Sure they can. Okay? So, I mean, does he think it's important for them to maintain their normal lifestyle? Absolutely. Okay? So, just because that's not working doesn't mean, so that individual, we need to work on different things. So, we're going to look at that. Moderate anxiety, we're going to look at cognitive reframing. We're going to say, okay, you know, you're getting up here, you probably got to, you know, you can't just be sitting in the bed now, you got to be sitting up or you got to be moving. It's kind of getting to the point that we got to direct you, we've got to make sure you understand what's going on. That patient may need to move around a little bit, okay, because they feel like they're, you know, they got to get up and do things. So at moderate, they're amped up. They're not really that bad off, but we're going to do the best we can with them, and we're going to redirect them. We're going to reframe what they're doing and focus them on, it's not that bad. We're going to get through this. Don't worry. So when do you see a patient that may be in moderate distress like this? Do what? Right. I mean, you may have the patient that's going down for a CT scan, right? And it's, you know, nurse comes in and says, CT's coming up to get y'all, right? I mean, so they get, oh my God, what's going to happen? What's going on? They're going to get diaphoretic. They're going to start amping up. So you need to stay in there and work with that patient. You need to try to understand what's going on. And then severe anxiety is when that patient's off the chain. I mean, they're a threat to themselves or to us, okay? They're walking around, they're cursing, they're banging on things, they're throwing things, their anxiety levels off the top of the chart, okay? So we need to isolate that patient. We need to make sure that we put them in a safe, quiet, protective environment. When they're all the way at the end of the spectrum, that's all we can do because we need to keep them safe. But we need to make sure that, you know, they are probably a threat to themselves or a threat to us. And that's not a good thing. So here's what the continuum looks like. No anxiety, mild, moderate, and severe. Okay, panic, you know, at the top end of it. And so we really have to work with those patients. We really have to deal with it. We are going to see this. Mainly these two. Mostly this. 10% of the time you're going to have a moderate type of thing, like Charlie's saying, you know, if they're going for a procedure or they just got, you know, maybe they just got the bad news too, you know. Maybe they just had some things go on. You're going to see these more at psych. That's when you PEC a patient. That's when you say that patient is going to be a problem. So you're going to see that more when y'all get to level 2. But normally now we don't. I mean, we've had, at the hospital, I've heard a couple of code whites. That's where the patient is becoming violent. So when you hear a code white at the hospital, that's a violent patient. Okay, and then these are our clinical manifestations in therapies, okay? So when you're verbalizing and you're in mild, you'll question, then the tremors begin, and then at severe, you become difficult, unable to understand. Motor activity, under mild, you might have a little bit of restlessness. At moderate, you get kind of shaky and tremors. At severe, you get agitated, and there's just no way to bring them down when they're at that severe level. Perception and attention, you're able to learn. That's why I say, from mild, most people have to be at that level to study, have to be at that level to understand, okay? Moderate is attention, focus, learning. Learning is slightly impaired. That's probably when you're taking a test. Y'all at the moderate level. And then severe is when y'all get to Ms. Gendron's questions. And y'all hit Ms. Gendron's wall and you go, these are Gendrons and I don't know, I'm going to die the hardest on the test. No, I'm just kidding with y'all. But you see, y'all drop back down to mild when y'all get to Mr. Keller's questions, right? So respiration, circulate, we talked about that. Y'all know about those things. And then anything else. So remember the little crazy person with all the things going on. Assess, assess, assess. Interventions, interventions, interventions. Evaluations, evaluations, right? So clarify those things before the test on your concepts so that when you get the questions on the test, y'all will be focused on it. Okay, any questions? All righty, that's it.